Okay, well, I don't want to wait too long to get started. I want to make sure we have the full hour for this webinar. Again, my name is Laura Burnham. I'm one of the CHAMPS project managers. And so just for a few pieces of housekeeping before we get started on the webinar today, please remember to put your phone on mute as you're listening to the webinar so that we can avoid background noise. And then if your line is noisy, I have the option of muting people. So if you hear the phone suddenly say, you know, that you've been put on mute, that's me probably muting you. It's a background noise. And I also want to note that please do not put your phones on hold during the webinar or else we will hear the hold music in the background as well. So without further ado, I'll get started today. Today's webinar is going to be on avoiding the pitfalls of hypoglycemia. And the presenters are Dr. Lori Feldman-Winter and Dr. Renee Boynton-Jarrett. And we have a few announcements, general announcements before we get started. So we want to let you know about our upcoming Wednesday webinars, which are held in collaboration with the Mississippi State Department of Health, and they're scheduled for Wednesdays from 11 a.m. to 12 p.m. Central Time. These webinars are open to the public and all are welcome to attend. And you can register for the webinars at champsbreastfeed.org/webinars. And so our upcoming schedule is in March. We will have a webinar on nursing staff issues and baby-friendly practices. And the presenter is Jennifer Ustinov. And then in April, we have CHAMPS Community and the Baby-Friendly Cafe Model, and the Baby Cafe Model. The presenters are Lucia Jenkins and Kimmery Bug and Danielle Lugrand. And then in May, we have a webinar on creating a prenatal education plan. And then in June, the Wednesday webinar will be on getting hospital leadership on board. And so you can get more information about these webinars and find out more information about how to join them on our website. We also wanted to let everyone know about the upcoming Blue Cross Blue Shield of Mississippi's Baby Friendly Regional Conference in the Gulf Coast area of Mississippi. This is going to be on February 16th. And this is the third webinar they have in their series of baby-friendly regional conferences. And so as you can see, we have several of our CHAMPS team members speaking, including Ann Mearwood and Kim Bug, Kathy Carruthers, and also Lori Feldman-Winter. We also have several upcoming 4-hour clinical skills trainings. These are in the Gulf Coast area as well, and they're happening around the same time as the Blue Cross Blue Shield conference. So we have trainings at Hancock Medical Center on the 15th. On the 18th and 19th, we have trainings at Memorial Hospital in Gulfport. And then February 23rd, later this month, we have a training at King's Daughters Medical Center. You can find out more information about attending these trainings at champsbreastfeed.org/events1. And we're really excited about these trainings. Kathy Carruthers is helping do many of these trainings, and the attendees from the trainings have rave reviews. So we also have an upcoming conference, Breastfeeding the Gold Standard Conference, in March, from March 16th to the 18th. And we wanted to mention this because Kathy Carruthers from CHAMPS, she will be presenting a plenary session on CHAMPS and the Baby Friendly Hospital Initiative. We also have another upcoming conference. This is our second annual Indian Country Breastfeeds Conference, focusing on sustainability and support. So this is in May in Albuquerque, New Mexico. And so this is a part of the American Indian Alaska Native CHAMPS program. And we're excited to have speakers including Cammie Goldhammer, Susan Carroll, the Chief Medical Officer of the Indian Health Service, and Beth Moody. And that's it for the announcements. I'm going to hand it over to Lori and Renee now, and they are going to give you the webinar, Avoiding the Pitfalls of Hypoglycemia.
Thanks, Lauren. This is Lori Winter. I'm the physician lead on the CHAMPS project, and I'm absolutely thrilled to have Dr. Renee Boynton-Jarrett speak today on these issues of hypoglycemia. So I am going to turn it over to Renee to allow her to introduce herself, and I will be moderating the session. So fielding any questions that you have, please feel free to enter them into the chat feature of the webinar. So you can type in, I'll keep track of those, and then we'll open up to questions. You can just raise your hand on the webinar if you want to ask a question. We'll hold all the questions till the end. So without further ado, Renee, thank you.
And Renee, this is Laura again. I'm working on assigning you presenter privileges right now.
Great.
Okay.
Well, thank you all for joining our webinar today. I'm going to share some thoughts about how we can avoid some pitfalls of hypoglycemia, which I know is something that we all really care about, want to avoid, and want to really do the best for moms and families in this area. And I really appreciate you spending your time today, and we definitely want to hear your questions, so please enter those into the chat as we go along. If there's something that's really important that's clarifying, just raise your hand. I'll be happy to try and take note of that and stop at that point in time. I don't have any relevant financial relationships or disclosures. I work as a consultant with the CHAMPS project, and I'm based at Boston Medical Center. So today we're going to talk a little bit about what neonatal hypoglycemia is defined as and who's at risk. We're going to talk about strategies to reduce the risk for hypoglycemia. And we're going to understand a little bit about the relationship between supplementation and breastfeeding success, okay? So before we get into tons of details, let's just take a breath and think about a hypothetical question. What if every parent or set of parents at the time they were prior to the delivery of their child knew that having immediate skin-to-skin contact would be able to offset transient hypoglycemia in their infant? Let's just say that piece of information was as widely known as other pieces of information that parents know, like use of a car seat. Let's just imagine what it would mean for every parent to be aware of that and what their expectations would be as a result. This is something that could be done that's achievable in many, many circumstances. And I begin with that hypothetical question because I know everyone's working really hard and trying to do an exceptional job with the work that they're doing. And at the same point in time, we sometimes, can get really into the details of what we're doing and not look at, well, what if things were different? So I want to think about if things were different, if parents had that piece of information, what would their expectations be from us? And what could we do more of to help meet those expectations and to also make sure parents were aware of this important information? So let's start right there. So many of you have seen infants, large for gestational age, mom who's had a history of gestational diabetes. These are infants that we're worried about, maybe behaving in a jittery fashion in the first hour or two of life. But this is an infant that we would screen based on what we know about risk factors for hypoglycemia. Even knowing that this child, this large for gestational age infant whose mom had gestational diabetes, is at elevated risk for hypoglycemia, what's the best method of preventing hypoglycemia before it starts? Let's talk a little bit more about some common risk factors of which this child has some. and then talk a little bit about what we know about normal newborn blood glucose levels, what we expect them to do just as a part of normal physiology, and ways in which those levels may vary based on some of our maternal and child care practices. So hypoglycemia refers to low blood glucose concentration. It is common that there will be a transient hypoglycemia in the first several hours after birth, and we expect to see a bit of a dip, but a return to normal and higher levels of blood glucose within the first 24 hours of life. Most neonates have several strategies that they can use to compensate for hypoglycemia. A lot of them are referred to as counterregulation. So they have endogenous strategies to produce and elevate their blood glucose, ketogenesis, gluconeogenesis, and glycogenolysis. Okay, so different strategies that they can use to keep up their glucose stores. Many of these strategies are just being triggered for the first time during the first several hours after birth, and so it's part of why we do see a transient dip as well. We know that the transition from the in utero environment to living outside of the uterus is a difficult one. So in the in utero environment, infants have access to glucose. They also have ketones, free fatty acids that are transferred to them via the umbilical cord. And in the in utero environment, we see on average a glucose level of around 54. After delivery, the cord is clamped, so that supply of free fatty acids and glucose and ketones is stopped, and that newborn source of fuel is abruptly stopped. And so the first 4 to 6 hours after birth, we do see a natural drop in the fetal glucose level in this new infant to about 45. So the clamping process is a pretty abrupt change for the infant, and we see a transition there. Now, we know that the infant brain has an enhanced capacity to utilize ketone bodies and glucose-sparing fuel. So they're already natural protective strategies that the neonatal brain employs to protect neurological function because of the very sensitive relationship between glucose and brain functioning. At the same point in time, in systematic reviews that have been published, such as this one we reference here from 2006, we don't see any evidence that treatment of asymptomatic hypoglycemia leads to the same or better neurological outcomes in infants that did not receive treatment. So this is for infants that are not symptomatic. So they're not having jitteriness, or they're not expressing any symptoms or repercussions of the hypoglycemia. So it's important to know because there may be broader differences between infants that become symptomatic and those that do not become symptomatic among those that have hypoglycemia. When we think about the causes of abnormal hypoglycemia among newborns, we have a couple buckets we think about. Conditions that cause a lower amount of glucose in the bloodstream, conditions that prevent or decrease the storage of glucose, the use of conditions that use glycogen stores, so the sugar that's stored in your liver, and conditions that inhibit the glucose use of the body. So we see several risk factors. So infants of diabetic mothers who use medications to control their sugar levels in the blood, those cross the placenta, and they can have an impact on the stores in the infant as well as their utilization of insulin. Infants that are large for gestational age or small for gestational age, premature infants that have a more more premature liver and more premature stores in the body. Late preterm infants are also kind of a special risk category where there's a lot of variability in their risk. And then post-term infants, so infants greater than 42 weeks gestation, as well as those who are less than 2,500 grams and those that are more than 4,000 grams. Associated neonatal conditions include like poor or inadequate nutrition during pregnancy. The baby or infant of a diabetic mother will produce excess insulin during pregnancy, particularly if mom is treated with medications. There can be severe hemolytic diseases of the newborn, birth defects or metabolic diseases, congenital metabolic diseases, birth asphyxia, cold stress, liver disease, and of course infections. When we think about the symptoms that we see in a baby that's experiencing hypoglycemia, jitteriness, cyanosis, apnea, hypothermia, poor tone, poor feeding, irritability, lethargy, change in mental status, and then seizures. So as we think about the measurement of a low blood glucose, the signs and symptoms that go along with hypoglycemia that we reviewed, and then our goal is to kind of resolve ultimately those clinical signs and symptoms after restoring a normal glucose value, right? So it's a process we're trying to prevent and get ahead of, but also to correct once we identify. We know that high blood glucose levels for moms with uncontrolled or very poorly controlled gestational diabetes lead to extra glucose on board for baby, often leads to excessive weight, as well as the ultimate status of large for gestational age, in addition to additional complications that can go along with diabetes during pregnancy. We know that our screening measures are not perfect, so we usually do the heel stick with the screening test with our glucose strips. It's easy. It can happen right at the bedside. It's inexpensive, but these can often be not very reliable, not perfectly reliable, and you also have to make sure that your tool hasn't expired. A serum lab test is our gold standard, but that's usually a little complicated to get done in the first 2 hours of life, so we use that as our secondary test. There are other tests that are not yet widely available, but are promising, so hopefully there'll be more accurate tests heading down the pike in the future. When we've looked at populations, across populations, at those that are below, less than, or equal to the 5th percentile for plasma glucose levels, in the first 2 hours of life, about those less than the 5th percentile are below 28. In the first 3 to 47 hours of life, below 40 is the 5th percentile, and then from 48 to 72 hours of life, below 48 is the 5th percentile. Okay, so we actually see substantially lower levels in the 5th percentile than our screening cutoffs in the first 2 hours of life. There's been a fair amount of controversy over the years about what level is concerning. So in the 1960s, for term, appropriate for gestational age babies less than 35, was considered in 1987 at less than 24 hours, less than 30 to 35. In terms of correlations with poor blood flow, altered brain functioning, less than 30 has been correlated. When we're looking at lower birth weight infants and the risk for adverse long-term outcomes, 47 has been a level. And then when we're thinking about treatment guidelines, there's been quite a bit of differences, and some of our hospital protocols may vary slightly, but less than 24 hours of age, treatment at 45, but 24 to 72 hours of age, treatment for levels below 50, and greater than 72 hours of age, treatment for levels below 60, which correlates with kind of the expected homeostasis that we're expecting in terms of the rise in glucose over the first several hours of life. So how low is too low, and what are the complications associated with hypoglycemia? What do we see as the risk? So there have been several retrospective studies looking at long-term cognitive effects of transient hypoglycemia within the first 3 hours of life. The UM study, UM's Universal Newborn Glucose Screening Policy, and early glucose concentration from all newborns. They looked at levels less than 35 and as a primary, and then those between less than 40 and those less than 45 as secondary, in order to investigate whether the policy of intervening at levels less than 35 milligrams with early feed or IV dextrose. And their primary outcome that they looked at retrospectively was 4th grade literacy skills and 4th grade mathematics skills based on achievement tests that were taken for those kids when they were 10 years old. This was not a study conducted at Braby-friendly hospitals, but done in Arkansas. From all of the infants examined, they found that 36% of their population had an initial glucose level less than 45. So a little bit more than a third of the population had an initial glucose level less than 45. When they looked at 4th grade literacy performance and 4th grade mathematics performance on achievement tests, they found a statistically significant difference among those who had levels less than 35 in the mathematics performance. I'll show you that on their table. So for both literacy and math, they found a lower performance in 4th grade based on levels of glucose in infancy in the first few hours of life. First check, less than 45, less than 40, and less than 35. So for all of those levels, they saw lower performance in literacy as well as math. And as you can see, the lower performance was worse depending on how much lower the hypoglycemia levels were. So less than 45 versus less than 35 is significantly poorer performance. So they found that the transient hypoglycemia was pretty common. 6.4% had less than 35. Less than 45 was nearly 20% of infants. They found a lower probability of being proficient on the math and literacy test in 4th grade based on having the hypoglycemia after controlling for multiple factors. But the probability of having a lower proficiency was more extensive for those who had the lower levels of glucose. And for those who had lower levels of 40 to 45, their outcomes were worse in literacy, but not in math. They gave a strong caution that these results do need to be validated because obviously we're seeing a correlation with long-term functioning effects of hypoglycemia at levels that are among this universal screening of all infants rather than screening of infants only who had risk factors or only those who were symptomatic. So they tested every newborn, not just at-risk ones. They didn't look at the difference based on the risk factors, which would have been important to know, whether those who had risk factors did worse. And they didn't have any information about skin-to-skin contact or controlling for breastfeeding. So there are things we didn't learn from this study. So another study that was recently published in the New England Journal of Medicine, October of 2015, looked at all infants greater than 35 weeks gestation at risk for hypoglycemia, and looked to see if those who were randomized to receive treatment that would help maintain their glucose level greater than 47, whether that was beneficial. So they treated all that had lower blood sugars than 47 in their randomization group. And they didn't see any positive effect of treatment on cognitive performance. So they treated all that had lower blood sugars, but they didn't see any positive impact on cognitive functioning or processing difficulties or neurosensory impairment. Now, there are some caveats and limitations of this study as well. Again, we do not know the feeding method that was used, or there was no stratification by feeding method. The protocol involved treatment with dextrose but not with expressed colostrum, so we don't know the benefit of that. Skin-to-skin care was also not reported. And the data don't really help us understand at what threshold or level would treatment be beneficial, because we don't see an impact. So there's still more to learn. So taken together, we have one study showing kind of a long-term impact on neurocognitive outcomes and functioning in 4th grade based on hypoglycemia that's worse with lower levels. We have another study that treats every symptomatic infant but doesn't find a benefit on more short-term neurofunctioning outcomes. So taken together, this is not great news. So it leads us to a critical question that really relates strongly to the work we're all doing. Can we prevent hypoglycemia? Because we have evidence that treatment of symptomatic infants isn't necessarily getting us the benefit we would expect it would, and we have evidence that hypoglycemia can have effects on neurocognitive function. So we worry about that. So what could we be doing differently that would enhance prevention? So the strongest existing evidence says that immediate and continuous skin-to-skin care is a really important factor for preventing hypoglycemia. So that really gets us ahead of the 8 ball, right? So this study by Moore and colleagues published in 2012 reviewed 34 randomized controlled trials. And they found that skin-to-skin contact increased the average glucose levels, the main glucose levels in infants with 70 to 90 minutes of skin-to-skin contact. So they found a statistically significant increase across these studies in glucose levels of infants that had skin-to-skin contact. So we're seeing a positive, protective, preventive effect. In addition, they found increased breastfeeding for 1 to 4 months by about 27%, and they found an increased duration of breastfeeding, on average 43 days, so a month and a half longer. So some additional long-term benefits of the skin-to-skin contact as well, looking across these 34 independent RCT studies. So when you know better, you do better. So if every parent knew there's something they could do to prevent hypoglycemia, As we saw in one of our earlier studies, we don't know which babies are going to have hypoglycemia. In the study that screened everybody, irrespective of risk, about late preterm infants, term infants that are small for gestational age, LGA infants, and those with mothers who've had diabetes during pregnancy. If they're symptomatic and their level is less than 40, we treat them. If they're asymptomatic and it's in the first 4 hours of life, aim for an initial feed within that first hour. And if their initial screen is less than 25, they should get treated. If their first screen is between 25 and 40, refeed and then determine if they need to be treated. After you get out of the first 4 hours of life, you want to continue feeding every 2 to 3 hours. You want to screen prior to each feed. If they're less than 35 on that screening, meaning they're not having the appropriate rebound, you want to treat them. And if they're 35 to 45, refeed and treat as needed after you recheck. So we do take a very special approach to managing very high-risk infants who have known risk factors. You don't want to feed at-risk newborns immediately, but you want to wait for the first 30 to 60 minutes of life, give them an opportunity to do skin-to-skin, an opportunity to breastfeed, or an opportunity to feed on a few milliliters of expressed colostrum. But you do want to obtain that first heel stick within the first no sooner than 30 minutes after they've fed. So you have about 30 minutes to an hour that you want them to begin to try and feed. Then within a half an hour, you want to check that first heel stick. So within the first 2 hours of life, several things should have happened. Skin-to-skin contact, if appropriate and possible, that very first feeding, and then 30 minutes after that first feeding, checking the heel stick. This is the protocol from the American Association for Breastfeeding Medicine. They encourage for healthy term infants that supplementation is not necessary for healthy term newborn infants. Breastfeeding within the first 30 to 60 minutes of life and then on demand, facilitating skin-to-skin contact, and frequent feedings, 10 to 12 times in 24 hours, more so than on a routine clock, 10 to 12 times. Glucose screening for at-risk infants or infants who have clinical signs or symptoms of hypoglycemia, and then routinely monitoring their blood glucose is not necessary. Obviously can cause some harm. We can get erroneous reads. We can injure their heels. They can get infections. It's not without risk, routine monitoring. So we want to make sure at-risk infants are screened and that the frequency of the screening and the duration is related to the risk factors and the individual infant's behavior and progress. And you want to continue screening until the infant has demonstrated a stable, normal level. And your bedside glucose screening test should be confirmed by a laboratory formal test. Many of you have algorithms within your hospital that you use. And this is one example. We have a second example as well for the first 4 hours of life. But we can talk in detail around these protocols, if that would be helpful, or around the difference between these protocols and some of the protocols you're currently using. An important thing that every protocol should have is an idea of when to stop monitoring, because this can be a real practice variability factor, and we can use some existing evidence and best practices to really help us know when to stop monitoring. So for this protocol, they recommend after 3 consecutive blood glucoses greater than 45 and a term infant at 12 hours of life. Stop monitoring for a preterm infant every shift until 24 hours of life. Okay, so you really want to think about a protocol that has not just the screening levels and treatment advice, but what do you do once things begin to improve, as we hope that they would. I'm going to change course just a little bit to talk about risks of supplementation. So what happens with an immediate supplementation of an infant who has a lower D-stick with formula? Well, you know, why is it important to consider other strategies? You know, attempt at breastfeeding, attempt at giving colostrum, other factors. Well, we know supplementation decreases the confidence of the mother. It decreases milk removal, so that just, you know, it's supply and demand. So if there's less demand for the milk, there's less production that will take place. It can lead to earlier weaning. We know for babies, there are increased risk for short and long-term disease because of the wonderful protective factors for the immune system that come through breastfeeding. There are changes in the microbiology and immune biology of the gut with the exposure to formula rather than breast milk. And then there can also be effects on the dyad relationship around latch, hormonal stimulation as well. So there are risks to supplementation. So just one bottle, you know, in response to low D-stick does have a potential consequence. There are pathways. So a couple takeaway messages from our talk today before we open it up to questions and ideas from the group. Neonatal hypoglycemia may have a lasting impact on development, and there are several studies that do sound the alarm around the impact that hypoglycemia may have on long-term brain development. We also know that there's something we can do to prevent hypoglycemia. Immediate skin-to-skin care within the first hour of life can help offset transient hypoglycemia. And this is something that's helpful for every baby. For screening, we know that every infant that's at risk, based on known risk factors and symptomatic, should be screened. We also know that test feeds are not necessary for infants. They don't need a test feed. And in fact, there's no evidence of a benefit of test feeds for preventing hypoglycemia, whereas there's evidence for the role and the value of immediate skin-to-skin care on preventing hypoglycemia. So I begin with the question we started with at the very, very beginning, because we all do this work because we really care about these families we're working with. We care about the moms, the dads, and the babies. We want to really do our best for them, and we don't want to do harm. So what if every parent knew that immediate skin-to-skin care can offset transient hypoglycemia? What if every parent knew that? What would their expectations be of us and our systems? You know, what would they want as the optimal care for their child to have the best start in life possible? Thanks all for your time, and I want to open it up for questions and comments.
Thanks so much, Renee. That was so clear and I think helpful. I would even broaden the question to say, what if every parent and provider, every clinician knew that immediate skin-to-skin care can offset transient hypoglycemia? You know, what do your clinicians know and do about this issue in your institutions? So we will entertain any questions. I don't see anything in the chat right now, but don't be shy. These are sometimes really complex concepts, you know, to kind of get our head around, certainly when it comes to the metabolism of the baby. And
hi, this is Anne. If no one has any questions, I just want to thank you, Renee. That was a brilliant webinar. I have a question. So I think maybe, I mean, actually, I'm not sure how many of the people on the phone are physicians, but we certainly know that from our work in Mississippi that many of the nurses and certainly community members and people who work for WIC are maybe, well, now they're all the people on the webinar are fully aware of this, but many of them were aware that, you know, skin-to-skin care is a really great preventive measure and are frustrated with the hypoglycemia policies and protocols that are played out in the hospitals. And I'm just wondering if either, well, Renee, I know you've done some work on this already, and Laurie, if you have suggestions for people who may be sitting on this webinar and thinking, well, I know, what am I going to do when I get back to the unit and, you know, everybody's giving the baby glucose water. Do you have, like, suggestions as to how people can act on the information?
I think that's a great challenge, Annan. You know, I would just say, with full disclosure to everyone on the webinar, sometimes seeing the difference that a practice change makes for babies and for families is what we need to motivate our colleagues and others along the process. But I do think one really important first step is to have an agreed upon protocol that really nicely outlines, this is the way we're going to practice, this is the protocol we're all going to use. And the good news is we don't all have to make that protocol up. There's some amazing existing protocols out there that are based on, you know, the best evidence and the best practices, and we'd be more than happy to help, you know, introduce and share those resources so we don't have to reinvent the wheel. But I think a clear protocol is so important. When I get called in the middle of the night about a question in the nursery, I like to check the protocol. You know, I feel more reassured by making sure that my practice is not just coming out of, you know, what I decided to do that day, but is really backed up by the best research and evidence.
Thanks. I agree. I mean, I would say that in addition, it wouldn't surprise me that the physicians that are continuing the same practice of giving glucose water to try to prevent or even treat hypoglycemia, that they just don't know the evidence, you know, that they're not aware of what evidence-based medicine would lead them to do in this case. And so without being threatening, you know, I think that a person who is in the hospital that has a good rapport with the clinicians, whether they're the obstetricians or maternal care providers or the pediatricians, begin to engage in a conversation and start with sort of motivational interviewing. You know, there's been some new evidence that has come out lately about hypoglycemia. It's really confusing, but, you know, one thing that we can definitely hang our hat on is this Cochrane review that looks at hypoglycemia being prevented through skin-to-skin care. So what do you think about that? You know, what do you see as the benefits and harms of doing that? And, you know, what are your worries about hypoglycemia, and what do you see as the benefits to giving the babies glucose water, formula, whatever it is, to presumably treat hypoglycemia, and then just seeing where they're at, and then through that really identifying where there are gaps in their knowledge base. And education is really everything. I think that every institution has opportunities for furthering the education. Medicine changes. You know, it's never static. Things are always being learned, and what we know today, we might laugh at 10 years from now. So I think we just have to always be open to the idea that new evidence comes out all the time and to challenge ourselves. I think this is a particularly volatile field because we're learning more and more about the metabolism of the baby and really understanding how to risk stratify. And we don't have the best evidence because nobody's really been collecting the variables that matter, such as skin-to-skin care and breastfeeding. So I think once we get more evidence and more researchers really looking at the variables that matter, I think it'll be much more elucidating, and then it's going to take time because you have to measure those things over time. So, you know, it's really all about having that connection and feeling comfortable with the clinicians to be able to open up that conversation. The other thing is to empower families. I mean, sometimes this is hard to do, but I think, yeah, we heard when we were in Mississippi last time that moms that are empowered with the information come in with a birth plan, get the best care. You know, so sometimes working through the community and really putting all this great evidence out to the community. It's not hard to understand. It just has to be presented in a way that can really empower and mobilize communities to act on it. Any other questions or thoughts?
I wonder what folks think is the biggest barrier to skin. I mean, this is a safe space, so it's a kind of space where we can talk about this and really think about solutions together. But I really wonder about the biggest barrier or the biggest barrier you're experiencing right now, and if others might have some solutions to share.
If you're on mute and you don't know if you have audio, feel free to chat in thoughts or questions into the chat box as well.
Hi, can you hear me? This is Philippa Howard in New Mexico.
Yes, hi, welcome.
Hi, I'm not seeing any slides. I would love to be able to see them, but for some reason we're just on the phone link. I think part of the problem is medicine comes from a model of pathology, not physiology, and nurses are expecting things to go wrong. So it's a mindset as much as anything, because everybody, not everybody, but a lot of nurses go, how can I really assess this baby if they're skin to skin with their mom? How do we know how much the baby weighs? We're looking at all these things. How can I do this while the baby's skin to skin? I want to be able to take the baby away. And it's a big mindset change to get away from that.
Yes, baby sick until proven otherwise. I was certainly trained in that era. I think things are changing. I think that, you know, medicine is changing, but certainly those that were trained 20, 30 years ago have that mindset, baby sick until proven otherwise. But I do want to say that part of your hospital policies and protocols can be about the newborn assessment occurring while skin to skin. We had to do that in our hospital. So that is just part of our skin to skin policy, that the mother becomes the environment in which X, Y, Z occurs. And part of that is assignment of APGAR scores, the first newborn assessment, any procedures that can be done while skin to skin are done, not interfering certainly with the first feed, but following the first feed. But the mom becomes the safest environment while skin to skin for that baby's assessment and treatment as a newborn, even if you deem that baby sick until proven otherwise, that in fact skin to skin care is a response to that concern, because that is the safest environment for that baby.
That's great, because we're working on getting on the pathway and working on changing our policies and getting more skin to skin. We do it inconsistently, I would say, at this point. But I did have a question. Are there handouts or a slideshow that goes with this? Because I'm not seeing anything.
Yes, so we do have the slides. There will be a recording, but I'll have to ask the team, home base.
Yes, hi, this is Laura. I'm one of the CHAMPS project managers. So we will have the recording of this webinar up online on our website. And every Wednesday webinar is on our website and available for the public to view. So you'll be able to find it there. Either this afternoon or tomorrow it will be up.
And there are slides to go with it, or handouts or something? or is it just the recording?
Yeah, so we post the recording, and then we also post a PDF of the slides.
Great. Thank you so much. Really appreciate it. These are awesome webinars.
Great. Any other thoughts in terms of testing every baby versus only testing babies at risk? You know, is that, again, a mindset that's shared that every baby's hypoglycemic until proven otherwise, so every baby's tested, or is that something that you...
Hello.
Yes, hi.
Hi. This is Kimmery Bug. How are you?
Hi, Kim.
How's everyone?
Welcome.
I just wanted to say that I totally appreciate the information. I learned a lot. And as Dr. Renee said, when we know better, we do better. It's impossible for us to do better if we don't have the information. And so I know as a nurse who loves babies and mothers, but mostly babies, that, you know, we have always wanted to uphold the best care for the babies, and that is what we felt was given to us and how we were trained. And yes, what nurses are trained to do is to know what's normal. And so then when anything is abnormal, of course, we get a little hyper about that. And so with this information, we should be able to, and with the policies, we have got to adhere as nurses to policy. So if and when, let me say when, these policies are changed, it will not be difficult for fabulous nursing staff to adhere to those. But we have got to work on getting the policies. I know I saw and heard a lot about normal supplementations that were still going on, and it surprised me as we were traveling. And so that's why these seminars are so vital, so that we can see that this is evidence-based information, that it is out there, it is, you know, everywhere around us, but we are just so overwhelmed and busy in our little silos that it is very difficult for us to pull those together ourselves. But together collectively now that we have this information through these collaboratives, I'm really expecting great things to advance and the needle to be moved, and for us to stop just doing routine supplementations of every baby. As we heard many times, is that there are very few hospitals in some of the places we're going where any exclusivity of breastfeeding is being done, because every baby has to get a supplement because of these concerns. And, you know, in the past, of course, we were trained that these were important concerns. So with this great information and, you know, these wonderful, beautiful slides that we're looking at, I love this picture that's up here of the hands. I know that we are going to continue to share, change those policies, and do better. Thank you.
Thanks, Kim.
Thank you, Kim. Thank you all for spending this precious time in your day with us. And if there's anything you didn't feel comfortable asking in the larger group, you can shoot us an email, and we will definitely respond. You know, our goal is, you know, to see everyone be successful and really be able to provide the care that they want to for families. You know, we all have the same goal in mind. And, you know, it takes a lot. It takes a village. We all have to do it together. And so anything we can do to be helpful, please let us know. And, you know, thank you so much for spending the time and your interest and your passion for moving this work forward. We know it's not easy.
Hi, so this is Laura. So I'll end the webinar now. Is that good, Lori and Renee?
Sounds great. Yeah, so just like Renee said, I think sometimes it takes a little bit of time to just process this information because it's complicated, and I think it's such a drastic shift in the mindset, and certainly is for many pediatricians and neonatologists to think about this differently. So we will certainly entertain any questions that come after the fact, and looking forward to furthering this conversation.
Great, thank you. So if you do have questions and you don't have a CHAMPS contact already, you can email us at champsbreastfeed@gmail.com, and we look forward to seeing you on our next webinar. Thank you, everyone, for joining us today.
Thank you.
Thank you. Have a great day.